All right, this is Dr. Sfakianos. I don't know if I even have to introduce him, but he's at Mount Sinai doing great work. And I'll be honest, I heard about ctDNA when I started residency, maybe a little bit. But now you go and it's everywhere, right? It's in every single poster. I went into each poster cell, ctDNA, renal cell now, bladder. So you were one of the first people to get involved with this. Mm-hmm. Give us the journey.
Yeah, so thank you very much for the invitation, first of all, and thank you for letting me speak about ctDNA. I mean, I think the big sort of overwhelming picture here is that everybody knew that this was what we needed to do. ctDNA, cell-free DNA, it started off with CTCs, circulating tumor cells. This concept of a biomarker in the blood was something that, everybody knew would take off.
What was there before?
There was nothing before. But the biggest problem, the biggest hurdle was technology. So the biggest hurdle was able to have a technology that allows you to actually get an absolute value or a value of either ctDNA, CTC, circulating tumor cells, with accuracy and in a timely fashion, because that's really important. And so that was always the biggest hurdle for this. And it wasn't until, Natera really put a lot of effort and money and really got the technology and was able to commercialize this. And that's when I first started. It was really literally somebody coming into my office and saying, we have this new platform, we have this new technology, we think it's really important. I was like, yes, absolutely, let's go. We're going to just do it on all our patients and figure out how clinically relevant it's going to be in the future.
Okay, so on a basic level, how is it done? What type of test is it?
Yeah, so in bladder, which is what I focus on, this is a tumor-specific assay. So we take the TURBT specimen, we send it to Natera. They run their platform, the Signatera. They do a sequencing on the actual tumor and then identify really what they will call clonal mutations.
Okay.
And once they have that data, then they can actually go looking for those mutations in the blood, actually doing a PCR-based assay. So the first one does take a little longer because they need to do the sequencing, identify, find the primers, and et cetera, but then subsequently, when you're just sending the blood, you can actually do it in a very timely fashion for patients, a couple of weeks.
So not very painful.
Nope.
Patient.
The best part about it is they actually have, I mostly use Signatera and Natera from Natera, so I could speak very carefully about them and with good detail. The best part about that company is they actually do a home test. So you just set it up and they'll send somebody to the patient's house, draw the blood, and then you get the results. So.
Cool. And when you get these results, what do the results look like? What are they?
Right, so the results are, they give you, I personally think the best way to look at the results is through time. So it's more looking at the trends of what's happening with the patient rather than the absolute values. I'm not quite sure what the absolute value means yet, and I think we need to do more research. But the beauty is we can see, you have a positive test before we do this treatment, now you have a negative test. Do we need to do further therapies or not? And these are the randomized trials that are extremely important. They're up and running. They're being performed, and I think we're going to have some really great data that's going to allow us to, I don't like to use the word, but maybe personalize care a little bit more. Not everybody needs to get adjuvant therapy. Mm-hmm. Now we can maybe identify those who should get it or those who shouldn't get it, even more importantly.
So what has the study shown? What does it help you do?
Yeah, so there's a couple of there's a couple of different aspects to it. There's what I would say the more urology focus, which would be surgically relevant type issues, and then there's the medical oncology. Okay. So the data really from the clinical trials was the InVigor data from Tom Powell's that showed that when you actually looked at adjuvant therapy for patients who had advanced disease post cystectomy, that those that were ctDNA positive only really benefited from adjuvant checkpoint therapy. That wasn't sort of the primary endpoint of that study, so now there is a subsequent study that's enrolling, really focused on that question. Right. And then we have the modern study, which is a study that's being run by Matt Galsky, the medical oncologist that I work with, that is actually separating patients post-cystectomy, treatment algorithms based on if you're ctDNA negative or ctDNA positive. I think the most important part is that the ctDNA negative patients, and this is what the Ambinder study has shown, don't benefit from any further adjuvant therapies. So those patients who are ctDNA negative, we probably can de-escalate their care by just going to surveillance, not necessarily treating them.
Wow, and that was, Ambinder used the adalimumab?
Atezolizumab, correct,
right.
yeah.
And so that study really showed the ctDNA negative patients?
Yeah.
Right.
From a urology standpoint, it's a study that I have proposed, and what our data has shown, and we published our series from Mount Sinai, is that the ctDNA negative patients who are clinically T2, T4, non-metastatic, when you compare those who get neoadjuvant chemotherapy and surgery to those who just get surgery alone, they have exactly the same outcome.
Wow.
So now we may have a biomarker that will allow us to choose which patients we can de-escalate or avoid neoadjuvant chemotherapy and just go straight to surgery if necessary. And I have proposed a large randomized study to study that further, but I think that's where we are now. We have lots of really good data, most of it retrospective, some of it, prospectively collected that is allowing us to hypothesize, to build really great clinical trials, both in the sort of urology space in terms of surgery, but also in the medical oncology for neoadjuvant and adjuvant therapies.
Wow. Has ctDNA been brought into any nomograms or anything?
Yeah, not yet, but that's what, actually, we just got a paper accepted in European Urological Oncology today. That is a study where we looked at all of our patients post-surgery who had ctDNA negative, and we compared their ctDNA outcome to their imaging, surveillance imaging. And there was basically 100% concordance between ctDNA negative and imaging. So the beauty about something like this is now that we can, patients don't have to necessarily come into the office, get all these scans. They can get their home tests drawn, we get the results and make a decision if we need to do something in terms of surveillance imaging.
You talk about bladder cancer patients who are older, maybe this is like the perfect patient population where
Correct.
You need something like this.
Yeah, and we've been arguing about tertiary referral centers a long time for bladder cancer. Really, cystectomy should be done high volume centers with high volume surgeons. And that usually means that patients have to travel.
Right.
A lot of patients will travel hours to get to the treating physician or the treating institution. And so this now can save quite a bit of travel time for all its patients.
Very impressive. Where are we going? What's going to be happening next? What's next and what's in 10 years, in your opinion? I won't hold you to it.
Yeah. I think it's a great question. I think for me, this is probably the most exciting clinical question that I've been a part of in my young, early career. I'm super excited about where we're going with this because I do think now we are going to be able to, quote unquote, have a personalized approach to how we treat patients. We've talked about personalized medicine from the idea of you have this mutation, we're going to give you this therapy. Well, now it's going to be like, you have this biomarker, so we should do X, Y, and Z. So there will eventually be an algorithm that says, if you have this disease and your ctDNA is negative, you could do this, et cetera, et cetera.
To have something that has such strong, strength to it, right, is like so unique. It's much more unique than some of the other biomarkers we use for other diseases we treat, and uses so much more rough, as opposed to this, which is. Yeah,
The big picture issue that you see here is that it could be used with any cancer because it's tumor specific. So any patient with a tumor that can get sequenced, we can use this to help with the treatment algorithms. And so colorectal cancer is really the cancer that has, is 3-4 steps ahead of like bladder cancer and some of the other cancers. And we can see that that's being used in that way in algorithms. It's used to make decisions on how we treat patients. And so my only caveat to all this is like there's a lot of work to be done.
Right.
And where is it going to be done first and how is it going to be done? So it may be a little more than 5 or 10 years, but it's really exciting about all the things that you can do.
That's really cool. Well, thank you so much for talking to us.
My pleasure. Thank you for the invitation.
Yeah, thank you.